A very good evening to all of you, and thanks a lot, Dr. Chandragowda sir. And I will be presenting the best abstract in clinical value that were presented in the recently concluded ASCO Genitourinary 2022. So almost approximately 600 abstracts were presented in the recently concluded ASCO GU, and we will be presenting the very important abstracts which are important especially for the medical oncology perspectives. So, starting from the prostate cancer abstracts, the first one that is very important is the Arasens study, and it is the trial of darolutamide versus placebo in combination with ADT and docetaxel in patients with metastatic castrate-sensitive prostate cancer. So it is a phase 3 randomized double-blind study, and patients were stratified by the metastasis stage like M1A, M1B, or M1C. So alkaline phosphatase was another stratification factor, either being within the normal range or more than the upper limit of the normal. So patients with a newly diagnosed metastatic castrate-sensitive prostate cancer with a performance status of 0 and 1 were randomized to receive either darolutamide at the dose of 600 milligram twice a day along with ADT and docetaxel versus placebo plus ADT and docetaxel. Important thing is here that docetaxel dose that was given was 75 milligram per meter square on day 1, and it was repeated every 28 days instead of 21 days. So this is something important, and the primary endpoint of the study was overall survival. There were multiple secondary endpoints like time to CRPC, time to pain progression, symptomatic skeletal event-free survival, and others, which we shall be discussing in the later slides. So the treatment was continued until symptomatic progressive disease or change in the neoplastic therapy or an acceptable toxicities. So these are the baseline characteristics of the patient enrolled into both the arm, and the median age was 67. Asian Pacific patients were approximately 35% in those who received darolutamide and 37% in the placebo arm. The visceral metastasis or the distant metastasis patients were seen in 17% of the patients who received darolutamide and 18% in the placebo arm. And the ALP stratification with more than the upper limit of normal was 55% and 55% respectively in both the arms. Coming to the primary endpoint, that is the overall survival, the addition of darolutamide to ADT and docetaxel significantly reduced the risk of death by 32.5% as compared to the placebo, and that was statistically significant. If you see the median survival in the Kaplan-Meier curve in the darolutamide arm, the median OS was not estimable, and in the placebo arm it was 48.9 months. And moreover, the overall survival benefit was seen across most of the subgroups. Coming to the key secondary endpoint, the time to CRPC and time to pain progression were also longer with the darolutamide arm, and the median time to CRPC was not estimable in the darolutamide arm, whereas in the placebo it was 19.1 month. The time to pain progression was again not estimable in the darolutamide arm, and it was 27.5 months in the placebo arm. So these are the other important secondary endpoints that were significantly better with the darolutamide: the symptomatic skeletal event-free survival, the time to first symptomatic skeletal events, the time to initiation of a subsequent systemic antineoplastic therapy. So these were important secondary endpoints that were significantly better in the darolutamide arm as compared to the placebo arm. Safety profile was more or less comparable between the two arms, and there were similar rates of death due to treatment emergent adverse events. In the darolutamide arm it was 4.1%, and in the placebo arm it was 4%. Hypertension was slightly more commonly seen in the darolutamide arm as compared to the placebo. However, when we see the exposure adjusted incidence rate per 100 patient per year. It was similar in both the arm, being 5. Mental impairment disorder was slightly more commonly seen in darolutamide as compared to the placebo. So the investigator conclusion was that addition of darolutamide to ADT plus docetaxel significantly prolonged the overall survival versus placebo plus ADT plus docetaxel in patients with metastatic castrate sensitive prostate cancer, and the median OS was not estimable in the darolutamide arm versus 48.9 months in those who received the placebo, and it was statistically significant. The overall survival benefit was consistent across the pre-specified subgroups, including those with de novo versus a recurrent metastatic disease at diagnosis. And addition of darolutamide significantly improved 5 out of 7 hierarchically tested secondary endpoints like time to CRPC, time to pain progression, time to first SSE, and time to first subsequent antineoplastic therapy. Adverse events rates were comparable between the two arms with no new safety signals observed, and thus the investigators concluded that darolutamide plus ADT plus docetaxel should become a new standard of care for metastatic castrate-sensitive prostate cancer. So this is one of the important trial that can be practice changing. Coming to the second study in the prostate cancer, and this abstract was of PROPEL study. This is the first line olaparib plus abiraterone versus placebo plus abiraterone in metastatic castrate-resistant prostate cancer. So this was the interim analysis of international randomized double-blind phase 3 study. Patients with metastatic CRPC without any prior therapy for CRPC group and who were ongoing on ADT. Docetaxel for hormone sensitive patients were allowed, but no prior abiraterone was allowed, and there were no screening for HRR mutations. So patients were randomized to receive olaparib along with abiraterone, olaparib dose being 300 milligram twice a day, and abiraterone dose being standard 1 gram per day, along with prednisolone, and it was compared with placebo along with abiraterone at the dose of 1 gram per day along with prednisolone. The treatment was continued till radiographic progression or unacceptable toxicity, and the primary endpoint being the radiographic progression-free survival by the investigator, and the key secondary endpoints being overall survival, time to subsequent therapy or death, the PFS2, ORR, HRR mutation prevalence that was retrospectively assessed, health-related quality of life, and of course the safety data. So these are the baseline characteristic for HRR testing, and trial enrollment was not based on the biomarkers, and the HRR genetic testings were done retrospectively using the biopsy or the blood sample at the baseline. So it was assessed using the NGS like Foundation 1 CDX for tissue and Foundation 1 liquid CDX for plasma ctDNA. And HRR mutation was defined as one or more mutation in the HRR genes as detected by either of the two NGS assay. HRR mutation status was established for 97.7% of the patients, and 27.8% of the patients enrolled in the olaparib arm were having HRR mutation, whereas in the placebo, 29% of the patients had HRR mutations. So coming to the primary endpoint of the PROPEL study, that is radiographic progression-free survival, the median PFS was 24.8 months in those who received olaparib plus abiraterone, and it was 16.6 months for those who received the placebo. This was by investigator assessment. And if we talk about the blinded independent central review, the median PFS was 27.6 months in those who received the olaparib versus 16.4 for those who received the placebo. So both of them being statistically significant. So olaparib and abiraterone significantly reduced the risk of progression or death by 34% as per investigator assessment, and it was consistent with the 39% risk reduction as per the BICR. The radiographic PFS benefit with olaparib was seen across all the pre-specified subgroups, including both the HR mutated as well as the non-mutated subgroups. Coming to the other efficacy, so the it is for OS data, it is still immature. For others, there were benefit with the olaparib like TFST and PFS2. It was not reached in both the arm. So the overall response rate was also an important secondary endpoint, and it was 58.4% for those who received the olaparib, and it was 48.1% for those who received placebo. The overall response rate thus was improved by almost 10% with addition of olaparib. Coming to the safety summary, the embolic or the cardiac thromboembolic events were slightly more commonly seen with olaparib, and as per the PARP inhibitor class side effect, the anemia, thrombocytopenia were more commonly seen with the olaparib arm as compared to the placebo. However, the incidence of new and primary malignancy and pneumonitis was balanced between the two arms, and no cases were reported of MDS or AML. Moreover, health-related quality of life as per the FACT P was comparable between the two arms over the time. So these are the most common side effects of the study. So as we can see here, the anemia, fatigue, nausea, diarrhea, constipation, GI symptoms, all these were more commonly seen in the olaparib arm as compared to the placebo plus abiraterone arm.
My apologies, sir. You are left with just 3 minutes to conclude your presentation.
So I was supposed to give a talk for 20 minutes, I think.
So by 6:40 to 7.
Okay, so but it started only at 6:47. Anyways,
Take
I will
your time.
complete
Take
it.
your time.
Good.
Take your time. Take your
Yeah,
time,
go ahead.
sir.
So the investigative conclusion: addition of olaparib to first-line abiraterone significantly prolonged the radiographic PFS versus placebo plus abiraterone in patients with metastatic castration prostate cancer, and these are the results as we saw in the previous slide. So the investigators concluded that olaparib along with abiraterone is the first combination regime to demonstrate a clinical benefit in the first-line metastatic CRPC regardless of HRR mutation status. That is very important. So coming to the third important abstract that was presented is the magnitude study, and it is the first line niraparib plus abiraterone acetate and prednisolone in metastatic CRPC. So there were two cohort and the patients were pre-screened for HRR biomarker status. So cohort 1 was having HRR biomarker positive patients, and in the cohort 2 it was biomarker negative, that is HR biomarker negative patients, and both the cohort were randomized 1:1 like into the niraparib versus placebo, and this was for the patients with metastatic CRPC without any prior systemic therapy, no prior PARP inhibitor, and prior abiraterone was permitted for metastatic CRPC if less than 4 months. And the primary endpoint of this trial was radiographic PFS by central review, and the secondary endpoint being overall survival, time to symptomatic progression, time to cytotoxic chemotherapy. So these are the HRR gene testing which was done, and in the second cohort was enrollment was stopped because of added toxicity and no added efficacy in the interim analysis. So these are the baseline characteristics of the two different cohort, and it was perfectly matched almost. Coming to the primary endpoint, the median PFS was significantly better in those who received niraparib along with abiraterone versus those who received placebo plus abiraterone. It was better according to the BRCA1 and 2 mutated patients subgroup, as well as for those who had all HR biomarker positive patients. It was better for those who received niraparib. So primary endpoint was met with the risk of progression or death significantly reduced by 47% in BRCA1/2 mutated subgroup and by 27% in all HRR biomarker positive patients. and the radiographic PFS benefit was consistent across all the pre-specified subgroup of HR biomarker positive cohort. So these are the secondary endpoint. I will not go into details. Adverse events were most frequently leading to dose reduction was anemia and thrombocytopenia. However, it was well tolerated. So the conclusion of the study was that this finding support the use of niraparib along with abiraterone as the first line treatment option for patients with metastatic castrate-resistant prostate cancer having a HRR gene alteration. So this underscores the need for test of HR gene alteration in this patient population, where we can choose the PARP inhibitor more wisely. Coming to the urothelial cancer, the important abstract that was presented is Atlantis study, and it is the maintenance rucaparib after platinum-based chemotherapy in metastatic urothelial carcinoma with DNA repair deficiency. So this is the final analysis of rucaparib comparison arm in ongoing adaptive multi-comparison phase 2 Atlantis trial, and a patient with advanced urothelial carcinoma with a biomarker positive for DRD. This is important. The DRD testing was done before enrollment. So only the positive patients were enrolled into the study and randomized to receive either rucaparib or placebo, with the primary endpoint being progression-free survival. So this is the DRD testing criteria. So I will again not go into the details. So there are more than 10% genome-wide loss of heterozygosity and alteration in 15 genes. So any of these two were labeled as a DRD positive patients. So these are the baseline characteristics which were equally matched. Coming to the efficacy of this study. So the PFS, that is the primary endpoint, the median PFS was 35.3 weeks in the rucaparib arm, and it was 15.1 weeks in the placebo arm. So although there was numerical improvement in the PFS with maintenance rucaparib versus placebo, but it did not lead to statistical significance, even though the magnitude was quite high. So the conclusion of the study was that the results support further study of PARP inhibition therapy in biomarker selected patients with urothelial carcinoma. So this is a trophy urothelial 01 study. This is the second important abstract that was presented of sacituzumab govitecan plus pembrolizumab in metastatic urothelial carcinoma after platinum-based therapy. This is cohort 3 of a multi-cohort phase 2 trial, and in this cohort 3, adults with metastatic urothelial carcinoma progression after platinum-based therapy was enrolled, and they received sacituzumab govitecan at a dose of 10 milligram per kg on day 1 and day 8, with pembrolizumab with a dose of 200 milligram IV on day 1, and the cycle was repeated every 21 days until progressive disease or unacceptable toxicities. The primary endpoint was investigator assessed overall response rate, and there was a null hypothesis that was considered to be true if the overall response rate is less than equal to 20%, and it was deemed to be rejected if the response is present in more than equal to 13 patients. So these are the baseline characteristics. Coming to the results, it is important to see that the overall response rate was seen in 14 patients, that is 34%, and thus the study met its primary objective with more than 13 response, with an overall response rate of 34%. And in this waterfall plot, you can see that the tumor shrinkage was observed in most of the patient, that is equivalent to 63% of all the patients. This is the safety profile of the combination. So the investigators concluded that the results support further study of combining sacituzumab govitecan along with the immune checkpoint inhibitors in earlier lines as well as the post-platinum for metastatic urothelial carcinoma. So coming to the last abstract, which is the keynote 564 updated analysis, and it is the trial of adjuvant pembrolizumab versus placebo in the clear cell renal cell carcinoma, and the updated analysis was presented as an abstract in the ASCO GU 2022. So adults with a clear cell renal cell carcinoma with intermediate high risk or M1 NED, like metastatic disease post surgery, and post surgery without any evidence of disease, without that there is no evidence of disease, were randomized to receive adjuvant pembrolizumab for up to 17 cycles, that is equivalent to 1 year, at a dose standard dose of 200 milligram every 3 weeks, and it was compared with the placebo. The primary endpoint being investigated assessed disease-free survival, and it is important to know that primary endpoint was also met in the interim analysis. So these are the baseline characteristics of keynote 564 study. So updated analysis of primary endpoint was presented here in this ASCO update. So 2-year median DFS was 78.3% in those who received pembrolizumab, and it was 67.3% for those who received placebo. So this was statistically significant, and DFS benefit with adjuvant pembrolizumab was maintained in this updated analysis as well. So also the adjuvant pembrolizumab improved the DFS across all the subgroups, including those defined by recurrence risk, sarcomatoid features, and PDL1 CPS scoring system as well. However, the maximum benefit was seen with those patients who are having the metastatic disease post surgery without any evidence of disease, and the hazard ratio for this subgroup of patients was 0.28. That was quite impressive, although the number of the patients enrolled in this subgroup was quite less. So these are the updated analysis of overall survival, but it is still immature for the overall survival data. Side effects are immune related side effect, which is seen with any of the immune checkpoint inhibitor. Apart from that, fatigue, pruritus, diarrhea, rash, these are common side effects seen with this pembrolizumab. So the conclusion of this study was that updated analysis also support the use of adjuvant pembrolizumab as a new standard of care for patients with RCC at risk of recurrence. So with this, I would like to conclude. Thank you.